All righty. All right. Good evening, everybody. My name is Dr. Tasha Gilmet. I'm a doctor of nursing practice, and we are here with Dr. Kelsey Steele. If Kelsey would like to go ahead and introduce herself.
Hi, I'm Dr. Steele. I'm one of our psychologists here at WellSpan Philhaven Behavioral Health, providing therapy in our community mental health setting.
All right. I am a nurse practitioner who specializes in menopause health. I do have my MSCP as a menopause specialist through the Menopause Society. So I literally talk about this all day long. So I'm really excited to share some information with you. So we are going to try to share the screen, and there we go. Awesome. So tonight we're going to be navigating sexual health for women with breast cancer. It is a wonderful topic. I don't think that we focus on just even female sexuality enough in the United States. There really isn't any medications that are available to even provide to women in general, whether they had breast cancer or not. So, I feel like this is a topic that we really need to start addressing and being focused on a more regular basis. It should, the hard part is not every person's educated. Even OBGYNs who have done OBGYN for 40 years really have not been super trained on what all goes in with sexuality, especially when we have a disease process in place or recovering from a disease process. So let's go on to, the big thing with breast cancer, when you have breast cancer and you've been treated, you go through treatments that will induce menopause. So induced menopause is when we have things like radiation, chemotherapy, removal of the ovaries, and your periods stop and outside normal menopause. So the problem with this kind of menopause as opposed to regular normal menopause is that it's more intense. The side effects, hit you like a million miles a minute. There's not that gradual change from, menstruating to when you space out the periods and happy menopause comes. This is right smack dab in your face. The quicker onset is so much more brutal than it is for regular menopause, which, I don't think a lot of people understand the severity of the symptoms when people go through induced menopause. One thing that we need to bring up, did you know breast cancer is a risk factor for sexual dysfunction? When we lose our hormones, that affects our estrogen, our progesterone, and our testosterone levels. So when we have, this immediate onset or cessation of menstrual cycles, when you have breast cancer, it is a primary risk for sexual dysfunction going forward. You don't have that availability to, again, gradually go through the cycle changes. Also, sexual dysfunction remains underdiagnosed and unaddressed among breast cancer patients and survivors. Again, the big thing that we're trying to get out there in the world is that even though you're going to an OBGYN, it does not mean that they know exactly what they're doing, how to prescribe things, and how to address it, or where to go for help, which is what's super important to get people through this really chaotic period of time. And it's very disruptive for not just only the patient, but also the relationship and the family. Dr. Steele, do you have anything else to add to that?
I don't. Sexual dysfunction and sexual health, I think, is something that we are, as a society, trying to become more comfortable with and trying to talk about a little bit more. And so hopefully normalizing some of these symptoms that people experience and normalize the topic can really help people feel more comfortable to seek help when needed. And I think that's a really big message too, right? We want to be there. We want to be supportive. So if any of this rings true, please know that there are providers here
Yeah.
that we want to address it with you.
Absolutely. And there's another really big thing is, whether you're, what other type of menopause you go through. A lot of times people feel, and I hear this a lot, feel broken. I'm just going to throw this out as I'm thinking about it. There's an amazing book, and I'm going to bring her name up a little bit later, Dr. Kelly Casperson. She wrote an amazing book. It's called You Are Not Broken. I highly recommend it it discussed testosterone, it discussed all sorts of treatments for libido and sexual dysfunction. She talks about breast cancer patients in it. So it's a really great read, and it's great on Audible if you are ever interested. But, going forward, this next slide, what is sexual dysfunction? Sometimes we don't understand there's so many facets to this. It can include, and we'll go around the pie chart there, negative feelings about yourself and sexuality, a decrease in arousal, a decrease in vaginal lubrication can result as sexual dysfunction, painful intercourse, decrease in sexual satisfaction, decrease in orgasm. This can also include something called hypoactive sexual desire disorder. And it could be a combo or all of these, it doesn't have to be just one. It can be many different parts of this pie here. With or without induced menopause, women naturally go through hormonal changes as their ovaries are shutting down. So many women, and you can even empathize with some of your friends, will go through some of these things like the decreased arousal, the decreased lubrication, the painful intercourse. That is the one thing in women's lives that will get worse as we get older. 80% of all women will have what's called genitourinary syndrome and menopause, which we're going to talk about here soon, in their lifetime. So what does all of this mean? It means the etiology of sexual dysfunction has many facets to it. It can be physical, it can be psychological. Again, symptoms worsen with age because of the lack of estrogen. The longer that we don't have hormones, the more symptomatic we can become over time. More than 70% of postmenopausal breast cancer patients report that they do have symptoms. And symptoms can begin even in perimenopause in all women's, but they worsen more abruptly with the abrupt cessation of menses. Things that we do need to remember: the treatment for breast cancer and the prevention of breast cancer can negatively affect sexual function. Again, radiation, chemotherapy can shut everything down, which abruptly brings on sexual dysfunction for some people through many, again, multifaceted reasons. The use of aromatase inhibitors, or AIs, and tamoxifen can trigger genitourinary syndrome of menopause. And we're going to again talk about that. What does all of that mean, that GSM? AIs drastically reduce plasma estradiol levels via inhibition of the conversion of androgens, testosterone, to estrogen. Sexual dysfunction can negatively impact relationships, self-worth, self-esteem, and overall quality of life. Sexual dysfunction also affects the relationship of the patient with her partner and how they proceed forward in life. Often and it's through lack of education, sometimes lack of just discussing things. A lot of times, at least in my practice, I find that partners don't understand the abrupt changes. They're used to seeing their partner as a 20 or a 30-year-old vibrant sexual person, ready to make babies. And then we get this abrupt cessation of not sometimes wanting to be touched, not wanting to have intimacy, for, various reasons. So a lot of times it's very hard for the person's partner, whether female or male, for them to understand the changes that person's going through because of their sexual dysfunction. It's so important, going in, as a segue into this next one, inclusion of the partner into understanding sexual dysfunction is absolutely imperative to the improvement of the dysfunction, of bringing the couple back together. It brings better understanding, which is where I personally always love to send people to Dr. Steele. Counseling of women for sexual dysfunction will have a positive impact into the overall outcome of the overall treatment of just everything, whether it's the breast cancer, the sexual dysfunction, the menopause, all of it together. Counseling is such an important part of the overall treatment plan for the patient and the family.
It can be really hard to want to engage in counseling. A lot of people, when they do come to me, we'll have a conversation about, well, this is medical. I don't understand how this is helpful. And once we start that therapy process and we start to really talk about how to expand sexuality, how to work within a dysfunction, meaning like, how do we work with pain if there is, or how do we work with some of the lubrication issues? people find it to be very helpful in just that expansion, which is such a big deal because sex for women can be very cognitive. And so when we are experiencing difficulties, either with like brain fog because of menopause or because of just daily life is really heavy, sometimes really attacking that from a cognitive perspective can be super helpful.
Absolutely. So what does sexual dysfunction include? We touched on some of this briefly. Sexual dysfunction can be involved with vulvar dysfunction. It could be irritation, itching, burning, general discomfort. It could be the lack of desire to be intimate with the partner for whatever reason, whether it's psychological or whether it's physical. It's increased symptoms of the genitourinary syndrome of menopause. Pain with penetration can often bring about like a ripping or tearing sensation. It can cause bleeding when there's tearing and a burning sensation, even post-coital if there wasn't any issues before. Even if penetration was okay and everything was fine, you can get a post-coital burn where it just feels like it's burning. It's on fire. Um, Decreased vaginal and vulvar sensitivity comes with, the shutting down of the pelvic organs, the lack of blood flow to the genitals, to the pelvic organs, decreases the overall sensitivity to penetration, the ability to achieve orgasm, the quality of the orgasm can change where you feel like, and sometimes you might feel like here it comes, and you're going to have this wonderfully explosive orgasm, and it just kind of puffs out like a little burst, not like a big firework display. Please know that you will always be able to get yourself to an orgasm if you're able to orgasm. Not every woman has been able to in their lifetime to achieve that, but if you are able to, you will always get yourself quicker than your partner will be to get to the orgasm phase. Again, decreased response to partner stimulation, where, back prior to treatment, prior to menopause, your partner could bring you to an orgasm or bring you to sexual satisfaction in whatever definition that is for you. A lot of times that kind of subsides. It is so much harder to achieve. Again, as Dr. Seal said, a lot of our sexuality sometimes is very cognitive. If we're trying to get there and we're in our brain, the sexual dysfunction kind of prevents us from getting to the overall goal of our sexual interaction with our partner sometimes. Treatments for anxiety. Please know that if we go on treatment because of depression, because of breast cancer, other cancers that may come up, they will help contribute to decreased libido and sometimes can't be fixed through testosterone therapy or other treatment therapies. So it kind of deadens things down with the nerve endings. We see it a lot with with Paxil. We see it with higher doses of Lexapro. So your SSRIs, your SNRIs are very, very common to kind of decrease the arousal state or the ability to achieve orgasm. So that is definitely something to talk with your healthcare provider. A lot of times we'll go to our family doctors for some of these treatments. We can talk about other medications that may help with anxiety and depression that may decrease that outcome for you. So, for instance, we'll talk about Wellbutrin. Wellbutrin is a medication that we use a lot for anxiety and depression that does not have any sexual side effects to it. So that's always a really good discussion to have with your provider who does your anxiety and depression medications so that it can improve your outcome. So we talked about, where I brought up symptoms of genitourinary syndrome of menopause. It just means the genital symptoms of menopause that include both the genitals and the urinary tract. Again, these can include the following: vaginal dryness, burning with urination, urgency with urination, frequency of urination, recurrent bladder infections, vaginal atrophy, which just means everything kind of gets tighter, it gets smaller. Please know if you stop penetrating the vagina over time, it may be to the point where it can shrink that you can't put anything in there. And sometimes we do have to do physical therapy to help that open back up. It can include incontinence, whether stress or urge, pain with sex, decrease in lubrication, a shortening or tightening of the vaginal canal and vulva, vulvar fusion. As we get older, there is a natural erosion of the vulva. Dr. Rachel Rubin, she's actually in Maryland, does awesome podcasts and Instagram messages about this particular subject. It is a natural loss of female anatomy that it can occur outside of things like lichen sclerosis or dermatology conditions that occur in peri and postmenopause, and sometimes younger. Light bleeding with sex due to tearing, and that's usually due to the lack of estrogen. Again, estrogen is something that's normally in the vagina, so are some androgens. So it makes our vaginas expand and contract, but when we don't have those hormones, our vaginas don't do anything but this. So anything going in can actually tear the tissue. Other symptoms, genital itching, you just feel like you have to scratch and so uncomfortable. Decreased orgasm sensation, difficulty achieving orgasm, and a decrease in vaginal sensation during sex. Just the feeling of penetration is sometimes hard to feel. So what can we do about all of these types of vaginal issues? There are things over the counter. The one thing that bothers me when I go on to Instagram is that there's a lot of information in there that once you start scrolling, doom scrolling, it'll throw more ads at you. But there are only so many things that, like, for instance, if you look at the second one, Bonafide's Reverie hyaluronic acid vaginal suppositories. The next one, hyaluronic acid vaginal suppositories. They're not going to give you, on the Instagram message, they'll say, make sex less painful. To a certain degree, yes, it will lubricate the canal. It'll adhere to the skin matrix of the vaginal canal. Hyaluronic acid is that stuff that makes our skin look young and supple when we're in our 20s and 30s. It's the stuff that goes away that, we start looking at our hands and we feel like we have grandma or mom's hands. That's the hyaluronic acid that kind of leaves the vagina too. So we can improve the water matrix of the vaginal canal through these hyaluronic acid vaginal suppositories. There's also other things like Luvena, Refresh, Replens. Those are just over the counter. Walmart, Target, Giant, Weiss, Amazon. Amazon has everything. So that's a really great place to look. And you can buy that discreetly. Sometimes buying some of these products, can be embarrassing for people when they're out in the general public. So I have to say Walmart is kudos to that, so that you can get some of these products in a very more inconspicuous way. So it's not as embarrassing for people. Please know that as you get older, everybody needs to use lubrication. It is not really average, or I hate the word normal. I want to say it's not common for people not to use lubrication, especially in your 50s and 60s and 70s and 80s. Our natural excitatory lubrication stops being created. And it has nothing to do sometimes with your sexual arousal to your partner. You could be in the mood and you just don't lubricate. It's a natural physiological change. It gets worse with breast cancer treatment and early cessation of menopause. There are many types of lubrications out there. I think silicone-based is a lot better. For some women, it can be a little irritating, but silicone doesn't get gummy. It doesn't get tacky. It's more slippery. So it's a little bit more enjoyable as opposed to like the water-based medication or lubrications. Astroglide's a really good one. It gets a little tacky, but it is a really great one that doesn't usually bother the vulva. Uberlube is a silicone-based one. That is my personal favorite. I give samples out all the time of that one. Ah Yes is another brand. They were actually at the Menopause Society, and they are great in terms of another lubrication. I do not recommend ever using KY jelly. Actually, urology doesn't recommend it either, because it's not really a great one for long-term comfort. It dries out pretty quick, can be very irritating to the vulva and to the urinary tract. Silicone-based lubrications can, as I said, increase irritation for some women. You got to be careful also if you are, and we're going to talk about using toys and things like that. You got to be careful with silicone-based lubrication and silicone vaginal applicators like dildos and things like that because it can break down the silicone. So water-based may be better. If you don't really care about replacing products, absolutely have at it. Avoid daily liners for discharge. This is something that I find a lot of people do because they have done it all their lives because they hate discharge in their underpants. Please know that's really not a great thing to do. Your vulva needs to breathe, especially when there's not a lot of secretions down there. Avoid overuse of soaps. It is a very American thing to wash your vulva with soap every single day. As you get older, your hyaluronic acid, it dries, your skin's already dry, so it's going to dry out even more. Really, the best soap would be to do Dove unscented sensitive skin, bar soap, avoid liquid cleansers just because it takes a lot to keep something a liquid. There's a lot of chemicals in it. Be careful of body washes. Never douche. That is horrible for you. Be careful of dryer sheets, fabric softeners. Anything with a scent really is not good against the vulva. There was a big kick also, the last couple of years, coconut oil for everything, put it everywhere, lubricate your skin, put it, everywhere you can think of. It's a fruit. It's really not something that should be in the vagina. You have to be careful with it. It can cause reactions. And the last one, I don't know whoever created warming lubrications, I don't know why they thought that was a really great idea. It really can be caustic to the skin. It can be very irritating. So if you use them and you like them, be careful with them, especially as you get older, because they may do the opposite of what they're doing now. So just be very careful with warming gels. All right. So what do we do for painful penetration with sexual dysfunction? There are many, many, many safe things for breast cancer patients. Most everything can be used except one on this list. So easy things that you can do over the counter would be DHEA vaginal suppositories. They're an androgen. DHEA is the precursor to estrogen and testosterone. So there are androgen receptors in the vagina and on the outside on the vulva. So Bezwecken is the brand that I recommend. It's a yellow stripe box. You can use it nightly till the end of time. You can also use it nightly and then taper down after like 3 months to using it maybe 2 times a week, 3 times a week. Intra Rosa is the prescription brand. I really run into trouble with this one with insurance companies. I really have to fight for this and I'm not always successful, but it's exactly the same everything as the DHEA over the counter. The only thing with the DHEA one is that it's not regulated by government facilities like any of the supplements. There are some places that third-party test their prescriptions, so you got to be careful when you're doing anything over the counter. But the Intra Rosa is one that is prescriptive. We know what's in that one. Osphena, not recommended for breast cancer patients. That one's for painful intercourse, vaginal dryness. Would not recommend ever to take that as a breast cancer patient until proven otherwise. You can, as a breast cancer patient, use vaginal estradiol. It is fine. It is safe. It is not systemic. Your partner can be exposed to it if they accidentally get a little bit on them. It can be in the form of a pill, which the brands are Vagifem and Juvafem. There's a cream, which is Estrace and Premarin. Most of us use Estrace because Premarin stands for pregnant mare urine. So most of us have all gone to Estrace itself just because it's cheaper and it's just as effective. Vaginal ring, there are two kinds. E-string is not systemic estradiol. It is one that just goes in the vagina, sits in there. You take it out every so often. FEM-HRT is systemic hormone replacement therapy. You have to be careful with that one, especially if you have a uterus in place also. Because if you have a uterus, you must use progesterone. If you have estrogen, progesterone positive breast cancers, I doubt if there's going to be anybody that will really prescribe the FEM-HRT, to be honest. Now, if you have a estrogen, progesterone, dominant breast cancer, you are more eligible for hormone replacement therapy and to use FEMHRT, but it is a interdisciplinary discussion between your gynecologist, your cancer provider, your breast specialist, whoever's all in your treatment team. So everybody needs to be on board and understanding, what we're doing there. There's also an estrogen suppository called Imvexxy. Also for painful penetration, I use sometimes a lot lidocaine just to take the discomfort out. The hard thing with lidocaine is that if you use it, your partner's exposed to it also. And if it makes you numb, it makes him numb. So sometimes it can be not a great outcome, but I would recommend maybe your partner use a condom at that point if you're using vaginal lidocaine, or wipe off as much as you can. And you would just put it like literally right at the opening to numb that painful area up. With painful intercourse, sometimes, especially if we have a lot of vaginal atrophy or narrowing of the vaginal canal, we use physical therapy. There are wonderful PTs in this area, licensed doctors of physical therapy. They're all women. I've not met a male yet that does pelvic floor PT. But what they do is they literally work in the vagina and they figure out, how to do that best. Should they start with estrogen cream? And then eventually sometimes they'll go to vaginal dilators and show you how to use vaginal dilators at home. One of the big things with painful penetration is you need to make sure, especially if things are getting really uncomfortable and you're trying to work through it, that there's enough foreplay and focus on the arousal phase prior to penetration. You get less ripping, less tearing, better reception of the vagina to receive something penetrating it. So it's definitely something to be focused on, and limit the use of medications that cause vaginal dryness. An example, antihistamines. An example, bladder control medications. Oxybutynin is one of them. We use that, for HRT in our regimen of medicines that we can use for menopause. But it also dries out everything. Know that your SSRIs, your SNRIs are going to be more drying, so you're not going to have as many secretions. You might feel more vaginal dryness with that. All righty. Adjunctive treatments, in addition to everything that we just talked about, and one of the big things is as we get older and we go through the change of life, you will be more prone to vaginal infections like bacterial vaginosis. We see that a lot, the pH imbalance. Sometimes estradiol cream or the estrogen cream can help a little bit. With estrogen cream, one of the big things I want to point out is that some women will start out, when they start using it, getting recurrent vaginitis, recurrent yeast infections. You got to work through that. You can't stop using the estrogen cream. You got to break the barrier. You will get to a point where that will stop, but you have to treat the infection, but keep going with the estrogen cream until you break the barrier and that your body accepts the estrogen cream and doesn't cause the infections. Another thing you need to do is rule out bladder infections. If you're having urinary urgency symptoms, that's always the first place to go, or first place to go. It could be just lack of estradiol on your vulva. I heard an interesting fact the other day that with the amount, or let me backtrack. If we would give elderly women, whether they're 70s, 80s in nursing homes and things like that, if we would give every woman vaginal estrogen, vulvar estrogen, we would save Medicare billions of dollars in urosepsis and UTI treatments. It's huge. I mean, this is one of the big things that would really help with urinary urgency frequency, UTIs. Urosepsis is huge, and it can cause death in older women. So if you have like your grandma who is in a nursing home who gets bladder infections, maybe have a talk. Estrogen might be the key to the problem. So because we know that does becomes more pronounced as we get older. Adjunct treatments. Don't be afraid to use and enjoy toys. The next slide, the little blue slide here. Siri is a company that I came across at the Menopause Society about 2 years ago. It is a company that is a male OBGYN in New York City, and he worked with a female radiologist, and they created pleasure toys for both partners and self. To use in the vagina. We know as we lose our estrogen, things fall, things change. Sex feels different in, positions that used to feel great don't feel great anymore. Things fall and change. So this company actually, the radiologist did ultrasounds as the products were being made on the participants who helped make the products. And they were made specifically for peri and postmenopausal women. They actually have a really great product that I tell everybody that I talk to about this in my visits. There's a product called the OUI, OUI. It's called Yes for yes in French. It is a clitoral vibrator that is made for peri and postmenopausal women because we know the clitoris requires different speeds, different vibrations, more intense vibrations to it, treatment to it. So bring it into the bedroom. Enjoy playing with it either with yourself or with your partner. Have your partner use it on you. So these are things that don't be afraid of them. Start embracing them. And I always, try to counsel patients whenever I'm doing my visits too, that it's again important to have a discussion with your partner because sometimes the partner, and Dr. Steele can talk more about this probably better than I can. The partner may feel inadequate because he can't get the partner to the orgasm or to where he got that partner before or got you before. So bringing clitoral stimulator into the bedroom, having it with the partner use it on you first or on, the cancer patient first, makes it a little bit more pleasurable and makes it a little bit easier sometimes to bring that arousal around. So I don't know if Dr. Steele, you have anything else more to bring with that.
I'll probably get to it when I get to a couple of my slides with
Perfect.
the toys. So we'll kind of touch on that in a few minutes.
Excellent. All right. Also, with incontinence, urinary continence, whether stress, urge, or just bladder leakage, there's help. Don't be afraid to ask for help. Please, if you are using pads in your underpants, we got to make sure that we use incontinence underpads or panties, because panty liners for menstrual cycles are made for blood and that type of a product, where incontinence pads are made for urine, in terms of the materials that are in the pads. And then adjunctive therapy, again, is going to be some counseling for the sexual dysfunction. All right. So with, a big part of sexual dysfunction is just libido itself, or the drive that most women have that steadily declines as women get older. The drive is to have intimate relationships, to have penetration, those kinds of feelings. Libido is also affected by other factors that include things like work stress, home stress, aging parents, kids in the house, just life stressors, breast cancer, those kinds of things can affect libido and sexual dysfunction. In some situations, especially with libido, it's better to treat, if you can identify the outside or external cause, it's better to treat that rather than sometimes doing hormone therapy if it's not needed. So, especially for younger patients, like 30-year-old patients that may not need testosterone therapy yet, based on, where they're at in their treatment plan. If there's something that can be remedied, if there's a trigger in addressing that, whether it's through counseling or addressing it with a relationship, those are the really good places to start right off the bat. And then include later on medications like Wellbutrin, testosterone, those kinds of medications. For decreased libido, there's many things that, go into this. Decreased libido makes it's a decrease in desire to make babies. Men can make babies till, the last foot's in the coffin. So, men do have their own issues going forward. There are some men that will have decreased libido themselves. So I can't, not include them into that, not every man wants to make a baby till the cows come home. But most men will have maybe even a mental thought about it. Women, everything shuts down. So sometimes that's part of it. Decreased libido sometimes is one of the biggest disappointments in women, or for women. Use of oral DHEA, I get this question a lot. Oral DHEA has not shown in any study to be an improvement of libido, testosterone levels. Actually can increase your lipid panel, can cause hair loss and other side effects if not really regulated. And over the counter, there is no DHEA oral that is FDA regulated for women in the US. Again, there's no US FDA approved treatments, period, for women with libido issues like testosterone. Now we do have other products like Vyleesi and Addyi that are approved for women with hypoactive sexual desire. And hypoactive sexual desire, I'll have Dr. Steele go through that and what all that means. Testosterone, we can be replaced. Usually, the way that I do it, I use male testosterone called Vogel XO. There's also Androgel. We got to keep your testosterone levels, so we have to monitor those and keep them within female ranges. It's going to be higher than the normal range, though, because usually the range, at least with WellSpan, is 2 to 45. I'll go up to 70, sometimes 100, but I don't like going over 100 with a testosterone level. Pellets have been a big thing in, society and media lately. Pellets are never recommended ever. They are not regulated for sterility, safety, efficacy. We have no idea what's in them. They can also deliver super physiological doses of testosterone to women. It's little hormone pellets that are inserted into the buttocks. They remain in there. They cannot be taken. They aren't taken out. They remain in there, metabolized over 12 weeks. So if something inserted is higher dose, you're kind of in a pickle. You got to like ride it out. Eventually your labs will go back down, your testosterone levels will go back to normal, but it'll take some time, but you're going to be symptomatic for a while. Vyleesi is an injection that we can give prior to 45 minutes prior to intercourse. You can't do any more than 8 injections in a month's time. There are some side effects that can be concerning. Acute pancreatitis is one of the side effects. Injection site reaction can cause dry mouth, constipation, irregular heartbeat. Wellbutrin and buspirone are 2 medications that can improve libido for some women. They help with anxiety, sometimes decreasing the mood swings that we have in peri and postmenopause, or as we go through treatment and are struggling with our self-identity with breast cancer. Sometimes they can help improve mood, that your arousal can come through and be a little bit more prominent for you. Addyi is a medication that is taken daily. It's a pill that is for hypoactive sexual desire. And again, side effects could be dry mouth, constipation. That one doesn't have as many side effects. I've had one patient take it and she said her heart raced a little bit, but I don't know if it's from anxiety of taking it or if it was truly the medication itself. There is an herbal medication called Restella by the company Bonafide. It's all herbal. It's been used in Europe over 20 years. From the reports, it should work in about 8 weeks minimum. It improves general sexual satisfaction, arousal, and orgasm quality for some women. And sex therapy can help couples transition during this time of life, and as women are experiencing breast cancer and their treatments. And again, men can have their own issues when there really is a menopause that can occur. There's a book out there called Menopause. It's pretty interesting, that talks about male sexual dysfunction. And then when you have 2 people with sexual dysfunction at the same time, sometimes it can be a little harder to navigate. And for some people, it's sometimes not, because they're both on the same page and their level of desire and intimacy goes to a different level rather than penetration, can be more emotional for that couple. All right, testosterone and its roles. There's not a lot of studies on testosterone with women with breast cancer. Unfortunately, menopause itself hasn't received much funding from the National Institute of Health to look at a lot of this stuff. So we need to, at some point when we can get funding back, study a little bit more about how can we improve the outcome for breast cancer patients and women in general with sexual dysfunction. There have been some studies that suggest that testosterone may increase the risk of breast cancer through the conversion of estrogen. It has not been proven to be true. Testosterone is fine. It's absolutely safe to use in breast cancer patients post-treatment. The use of aromatase inhibitors does stop the conversion of testosterone to estrogen. That's always just a helpful thing. Use of testosterone requires frequent labs to make sure that the levels of testosterone don't go super physiological. Again, you could have hair loss, facial hair, clitoral enlargement, deepening voice, male traits that kind of pop up. And I've seen it. So it does happen if we're not careful. To find the perfect level, it's to be based off reduced symptomology and no adverse effects rather than specific numbers. Some people will do better at 100. Some people will do better at 55. So there's not like a specific testosterone level that we're trying to get to. We're trying to get you to where do you feel best with your sexuality, and have you had improved arousal and libido with your testosterone dose. So I still want to make sure again that you stay within female dosage range and not male territory. All right. Okay, the role of testosterone with women. Again, there's no approved treatments in the US. I usually go through CVS. They have actually been the most cooperative of all the pharmacies. I will usually do a box of 60 tubes and put 1/10 of a tube on your inner thigh or calf after a hot shower. Um, that's usually how I would administer testosterone. And then based on your numbers and how you feel, we'll go off of how much more or less do we need. We have found that testosterone helps with mood. It's libido can be a mood, and it's also the drive that we talked about earlier. It improves in cognition, bone health, and muscle strength. Actually, and the fun fact, there's more testosterone in the female body than estrogen because testosterone converts into estrogen in our body. Estrogen is made through the androgen pathway. The ovaries and the adrenals produce testosterone, which converts estrogen through the enzyme aromatase. Compounded testosterone can be applied, and this is sometimes very helpful, to the vulva without causing a clitoral enlargement, and can improve vulvar sensation and improve vaginal health, improve blood flow, plumps up the tissue, and improves clitoral atrophy and decreases sometimes irritation. And you can get one that has estradiol and testosterone together in one cream, and it's applied to the vulva. That can be compounded by your GYN or your menopause specialist. Women with normal physiological testosterone, I thought this was a cool fact, have a decreased risk of breast cancer and heart disease, they found. However, testosterone is not approved for preventative health. That is one thing that leaders in the US right now are trying to do. They're actually, if anybody's ever interested, they just did in front of the FDA a 2-hour leadership presentation of why we need to change hormone therapy in the United States for women. It is found on YouTube. You could look it under like FDA leaders in and hormone therapy, and you want to find one that says 2 hours, and it's really, really cool. A lot of the great leaders of the US are there presenting their documentation. If you're ever interested in listening to just more about our body and hormone therapy. Oral estrogen affects testosterone levels. Transdermal estrogen improves testosterone levels. So that's a really cool thing. Oral is not, estrogen is no longer first line, it's transdermal. There's higher risks with oral estrogen if you're able to do hormone replacement therapy. So a lot of us will go straight to transdermal, which means through the skin. And then, however, testosterone can be used on its own, meaning that you don't need to use estrogen to use testosterone. It can be used all by itself. There are, again, no FDA-approved preparations of testosterone for women. We can compound it. We have what I talked about earlier, the Androgel, the Vogo Exo, that's my favorite. There are some compounded injectables, and that we do have pellets. Pellets really should be last resort if people just aren't absorbing it, and you need to make sure you go to a reputable provider who knows where their supply is coming from. So that's the one thing I can say about pellets. Again, Pellets are never hormone or approved for hormone therapy, but they are very popular. And the dosing of testosterone is 5 milligrams today, or today, listen to me, 5 milligrams a day. So one tube of like the Bogo XO has 50 milligrams, so you'll do 10 days worth, which delivers 5 milligrams a day. There's no way to get it exact to 5 milligrams, so you kind of have to like use like a pea-sized dose on the skin. All right, so I'm going to hand this over to Dr. Steele to talk more about the behavioral part of this.
So much good information. Thank you. I always learn every time I come to one, even though I'm part of the presenting. But well, not one thing, but an important factor to remember is that as somebody is going through, whether it's a cancer diagnosis and the treatment regimen, that emotions and moods and they're all okay. And so recognizing that to be authentic and to go through it, make sure that you're able to express them and feel them and identify them. Identify them is a really big deal. Usually we stick with umbrella words, of like, I'm sad, I'm anxious, I'm angry, and sometimes getting more specific can be very helpful and even empowering of like, okay, this is how I actually feel, right? I feel betrayed by my body. I feel annoyed at the treatment regimen or whichever. I feel sad, right? I feel defeated, other ones. So really being able to recognize and practicing that. We're not good at that as a society. But really trying to also have a good support with whatever emotion you are experiencing is that sometimes when people go through really intense things, their social supports shrink quite a bit. And that can be very functional and very effective. And other times it can be a little bit isolating in the sense that maybe you're frustrated with your partner, right? Maybe you're frustrated with the person in your support and you don't have somebody else to talk about that with. If you are trying to balance your health and your sexual health and your sexuality, trying to find a support system outside of your partner can be really effective, because once that type of tension and stress really bleeds in, sometimes it can be hard to work through that effectively. So having somebody outside of your partner and trying to find time to date your partner. I recognize that that is probably not the first thing on the list of priorities when you are going through some type of treatment or medical diagnosis. And recognizing that when we have the threshold for it, it can be very, very beneficial for the emotional and physical connection as you're going through hardship. So really, really keeping that in mind at different times. And they don't have to be really extravagant. They can be, a carve out, a picnic outside, or I don't know, going for a walk or something that isn't physically demanding, or if you're able to engage in that can be really helpful. That kind of ties into that recognizing our threshold and implement our own boundaries, is that sometimes people feel really pulled to challenge themselves to do all of the things that they've already done. And sometimes that's just not effective for our healing process. And so really being mindful where you're at. There is that threshold tolerance, right? Where some days we can engage in more activities. And if we're not careful, we're going to be down for the next 3 or 4 days. And so being really mindful where your body is and how you respond to that. So that's kind of just like an overview with some of the behavioral health pieces. Switching to sex. I don't think I can actually. Oh, perfect. Thank you.
You're welcome.
What can sex therapy help with? I am really trying to normalize conversations about sex because I don't think we have them enough. And I think that they are often censored and filled with shame and guilt, even though it's such a natural process. Throughout somebody's sexuality, I think body image changes and concerns come in. We've talked a lot about like arousal and our bodies change in that. And I always like to use the analogy that our bodies are like a dimmer switch. We're not a light switch, right? And over time, sometimes we can maybe go quickly up the dimmer, but other times it's going to take a little bit for us to get there. And so really recognizing what you can do to dial up, whether that's for yourself, what your partner can do to dial up, can be really, really helpful. Because what I have found is that when individuals start to experience sexual dysfunction symptoms, okay, so whether that is decreased arousal, decreased orgasm, sensation, a little bit of pain, anything, it's really personal and can really be personalized into their body change. And so knowing that that's super normal, we as women go through so many changes, whether that is puberty to pregnancy and postpartum to menopause. I mean, we really got the hard end of the stick here. And so recognizing that each stage of life, your body will naturally shift. And so really trying to normalize some of that can be helpful, especially as you are going through this process and the psychological impact of that. Um, and trying to be really open with redefining our sexual self. So I talk a lot about the difference between spontaneous arousal and responsive arousal, and that can be really helpful. Again, kind of that dimmer switch or that dial is that typically individuals are very used to that spontaneous desire, right? You see something, you're watching something, you read something, you have a memory and it pops up and you're ready to go. When we start going through mood symptoms like depression and anxiety, or any other mental health concerns or any health concerns, sex is going to be one of the first things to go. And when that happens, we then often blame ourselves of why can't I get there? Why can't I do this? Why don't I want to do this? Right. And with that, sometimes we just want things to be easy. And so when it's not easy, we then avoid, we disengage. We don't maybe have the confidence to expand. So trying to recognize and understand that that responsive desire is really, really helpful in knowing what you'd want, learning how to communicate what you want. We briefly touched on toys. I'm a huge fan of toys. I think that it is really important. I often find that couples will miss the mark and a partner will buy toys for their partner to say, hey, let's do this. And then the receiving partner, typically female, will say like, holy cow, this is really intimidating. I don't know what this is. What is this interest? And it can cause a lot of cognitions and anxiety. So one powerful and empowering thing that you can do is be part of that. Be curious. Pick your own out. If it's your first time, please do not go for something that looks intimidating. Anything that can cause some stimulation can be very helpful. Clitoral stimulation can also, you don't have to, and I'll be very direct because this is just naturally how I talk about it. But obviously like trying to stimulate the clitoris right on the top, like is very overwhelming for people. So I really encourage people to get to know your body. I find a lot of people have never actually explored their vulva. They've never explored their vagina. And so really being open to the fact of like, if you are experiencing body changes, it can be very helpful to try to get to know yourself. This is not a secret cave that should never be discussed or touched. It is something that is okay and you can be proud of and you can look at it and you will survive that and you should. Very big on that movement. That kind of coincides already with what I've talked about with kind of trying to reestablish that connection with your partner. Expansion and understanding that penetrative sex is not the only way to connect is very important. Sex play, I like to say sex play because I think anything that is involving our genitals can be foreplay or sex play, but it can be really satisfying and enjoying and so or joyful. So really allow yourself to engage in different types of things. There's lots of cards out there that can give ideas for sex play. There's a lot of books that can normalize and activities and trying to find that communication with your partner. Because I oftentimes, when I work with individuals, they have a really hard time saying like, we've never talked about our yes, no's, and maybes. And so that can be eye-opening within itself of just trying to explore some areas. Let me see here. I did want to touch base a little bit with dilators. Sometimes people do go to pelvic floor physical therapy and can be very overwhelming. Us therapists that do work in the sexual health realm can help. So if that feels intimidating and you're feeling really stressed and anxious about it, counselors can absolutely help with that relaxation practice and can normalize some of that. So please don't shy away if it's seen really overwhelming.
Awesome. All right. Other things important to remember is always call your GYN with any unexplained vaginal bleeding and concerns about sexual dysfunction. They can absolutely provide the gateway to treatment and referral to counseling. So they are a really great first line. To find if, WellSpan Health has providers that are part of the Menopause Society. We have certifications in this. We do have other providers, especially here in my office. Lisa Leitzel is another nurse practitioner who's wonderful with this. She does a lot of this stuff too. And because it is so important to find a provider that makes you feel seen and heard and makes you feel safe to discuss this. It is intimate. It's very private for some women. So we want to make sure that you feel like you're in a safe environment. You need to find a provider that provides that to you. Please know that menopause is not the end of life. It's just the beginning of a new amazing chapter. It is what you make it, and embrace it. Things may seem desolate and empty and things like that, but with treatment and help and seeking that help, things can get a lot better. Learn to love yourself, your new self. Whether you had a mastectomy, whether you had a hysterectomy and an oophorectomy where they took everything out of your pelvis, and I'll just share a little bit. I'm a uterine cancer survivor at the age of 50, and it was very hard for me to find that you just feel like when you lose everything, you kind of lose a little bit of the womanhood. So, it is very hard, and, good support really will get you through too. And you need to learn to love your new self. Talk to your partner, include him or her in this ongoing transition for a better transition. You can feel vibrant, you can feel awesome through this time. Again, if you are eligible for hormone replacement therapy, don't be afraid to reach out to a provider who will provide it to you, or at least have the discussion. You deserve to have the discussion, whether it's a yes or a no. You deserve to have the discussion. And last, find the humor in all of this. Laughter is often sometimes the best way to get through it with you and your partner. So find the joy in just even the smallest things. And then I did add into here's some major leaders in the US right now. Highly recommend checking them out on YouTube, Instagram. I know some of them have TikToks and things like that, but Dr. Mary Claire Haver, she was just on Oprah the other month talking about menopause. She actually helps with menopause and weight loss. Dr. Rachel Rubin is a urologist and does sexual medicine. She is literally in the next state over. And then we have Dr. Kelly Casperson. She does urology also. She makes or created the book You Are Not Broken. She also has the podcast You Are Not Broken. And I did put a little information down there for you too. But they are such great people and they're inspirational. They have great information and it's cutting edge. And they all dispel the Women's Health Initiative from back in 2002 to make people feel safer to pursue using testosterone and using estrogen, progesterone, or whatever you're eligible for to make life better. So that is our presentation for this evening. So
Thank you very much. It was very informative. I enjoyed hearing everything you had to say and teach. Can't wait to share this with more people. I know that some people didn't log in, but I'm sure that this will be used. Again, like you said, it's a private situation, so I'm sure a lot of people aren't readily anxious to say, yes, I want to hear about it. But I know that a lot of women and men could use this information. So
yeah, and again, I'm at Tri-Hill OBGYN if anybody wants.
Right up the road.
Yeah, right up the road. So yeah, Tri-Hill OBGYN if you ever want to have the discussion of what to do medicinally for libido and things like that, or just even have the discussion about it and menopause health. And so, because there's a lot of help out there. You just need to, don't be afraid to ask for it.
Can you repeat where you're at again? Because I didn't catch that, or spell it for me so I can write down.
Yep, I'm at 1693 South Queen Street here in York, and it's called Tri-Hill OBGYN. And tell your friends about us.
Thank you.
You're so welcome. Any other questions, thoughts, input?
What's your name again?
Tasha, Taasha, and my last name is Guillemette. And that's spelled Guille, M as in Mary, Ette.
Thank you.
Welcome.
And I'd like to just put a plug into Tasha and I think Kelsey as well coming to speak at our breast fair coming up in September. So September
September 20th.
20th, the Saturday.
Mhm.
Mhm. These ladies will be there to expand on the subject that they were just speaking about. So maybe want to tell your friends, and it's a great time to meet them and hear some more, hopefully.
Yep, and don't be afraid to bring questions.
And friends, because they probably need to hear it too.
Yeah, I can
So
talk
maybe
about
we
sex
should-
all day long, so.
Thank goodness. I love that we have you.
Yes, I agree. All right, ladies. Well, I'll let you go ahead and get back to your evening. And if anybody has any other further questions, please go ahead and just reach out, or and I'll go ahead and forward them on to you.
Awesome. Thank you. Thank you so much for having us.
Thank you.
Mhm.
Have a good night, guys. Take care.